Let me work on sharing the screen here. You guys see that?
Yes, sir, we do. Thank you.
How's that?
I think it's in presentation mode, so you might be able to swap it to presenter mode at the top. I think display settings.
Swap. There we go.
Yes, perfect. Thank you.
All right, guys. I know we were supposed to do, the pulmonary rehab this week, but as we discussed last time, there's going to be new guidelines coming out pretty soon. So, other than doing stuff that's going to be dated in a few months, I wanted to switch things up a little bit. So today I'm going to talk about sleep health and COPD. Nothing really relevant here, at least in terms of this talk. So one, I'm just going to review kind of sleep health. It's something that's in the news a lot now. Discuss sort of the implications of sleep in West Virginia, and then provide an update on COPD and OSA overlap. So, what are the benefits of getting healthy sleep? So it lowers your risk of serious health problems. What has a big impact on sort of mental health issues, and is actually not only for like depression, anxiety, but there's actually a lot of work at R&I looking at people in recovery for substance abuse. And one of the first indications that someone might relapse, which is really sort of interesting, is they start developing insomnia. So that might be a good marker for someone who's in treatment and then going to potentially relapse. There's been a lot, and there's a big effort at NIH to really understand sort of brain health, Alzheimer's, and cognitive ability in later age, and sleep. There's certainly data that supports that better sleep leads to improved or more robust response to vaccines, and David Dinges over. The other thing I'll mention is David Dinges has done a lot of work in this, and our guys over at R&I are doing a lot of work on this, looking at just like cognitive decision making, quick decision making, and they do research in sort of D1 athletes, special forces guys, looking at they put them in these stressful situations and how efficiently and appropriately they make decisions. And obviously with better sleep, these guys perform at a much higher level. As we've been talking about this for years, but actually last year the American Heart Association actually added sleep, which should have been there before, to life's essential aids. So these are things they talk about that is really essential for cardiovascular health, and sleep was added there. And there's been I think one of the reasons there's been such a big push and much more interest in sleep and health is all the wearables people have now. So probably a lot of you have had a patient come in and say, "Oh, look at my health data," and sleep's a big part of that. Whether it's an Apple Watch, Fitbit, whatever someone's wearing. But this is really sort of a eye-opening slide when you look at percent of people who reported short sleep duration, and I'll kind of show you the health impact of that. I mean, it is like a epidemic in Appalachia. Almost half of people don't get adequate sleep, and I don't have a great explanation for that. I would love to hear some thoughts, but some of it might be how we do with sleep disorders and diagnosing sleep. Now, again, this is self-reported, but that's pretty impressive. It's it's the worst in the country almost. How do we do in sort of the primary care setting and thinking about sleep? So this was a study, obviously an older study now, where they had patients coming into a number of primary care clinics complete different questionnaires, which would suggest, what is your risk for obstructive sleep apnea, insomnia, RLS, narcolepsy. And then the primary care provider actually sort of ask about these things. And you can see there's about over a third for insomnia and sleep apnea. Again, at least at risk, but the primary care providers really didn't ask anything sleep related. And when you look at just kind of overall mortality, this is from the Sleep Heart Health Study. So these were patients who underwent a sleep study. I think most of these guys were public workers. That might have been the Wisconsin cohort, but they were similar. And said, "Do you want to do a sleep study?" They said, "Sure." And if they found sleep apnea, they said, "Here are your results. Do with it what you will." And when you look at sort of survival and mortality over time, obviously the worse your sleep apnea, the worse your overall mortality. And this was from the mortality risk by insomnia. It really seems like the 6-hour mark really puts you, if you have insomnia and really sleep, at least report sleeping less than 6 hours, that's an important cutoff point where you really start seeing poor outcomes. So poor sleep or inadequate sleep definitely has a big impact on your health. And I like, the one thing that interests me about sleep and sleep disorders is I feel like you have an upstream impact on people's health. So much of what we discuss even in this echo is this downstream. Patients have bad established, COPD, ILD, and the disease is there and it's already progressing. So we're really at the downstream end of that, where when you address someone's social needs, health needs, you go upstream from that. So it has downstream impact on cardiovascular health, pulmonary health, metabolic health. So I think that's why sleep is, really an important thing for people to discuss. And it's, uber important in West Virginia. Not only do we have terrible sleep metrics, but we, bad outcomes in heart disease and COPD as well. And then when you look at our obesity, I mean, this is almost an unbelievable math. Like, we're going to be over half our population is going to be obese, I think, the next time they check, they do this analysis. So, when I looked at, I sort of got interested in this a number of years ago, and this was a study where we looked at patients admitted to the hospital with obstructive sleep apnea, and we screened them in the EMR based on, kind of BMI and some other risk factors, and then did an assessment on, could we get them established on CPAP therapy at discharge. So really what this study found is we miss a lot of people with obstructive sleep apnea, and even the ones we treat, we don't have a lot of success, at least with CPAP therapy. So based on that small study, we looked at the Medicaid database, and we did a large analysis of our Medicaid database, looking at sort of diagnostic codes and what we would expect from national data on the prevalence of these different disorders. And as you can see, we actually do a pretty good job of calling COPD. Some might argue that our patients are overdiagnosed at times without even PFTs. But, we didn't do a great job at identifying obstructive sleep apnea. And, we got out to some of our community practices and FQHCs, and, always take this chance to thank Dr. Doyle, who really helped a lot with this project, just with some thoughts. But, almost everyone we talked to thought, OSA as a disorder was very important, but they had no confidence in identifying or managing CPAP therapy. So what about, COPD and OSA in West Virginia? And, there's been a lot of work on this. It was back in, 20, 30 years ago, this so-called overlap syndrome was described. And, the reason folks were very concerned about this overlap syndrome is, obstructive sleep apnea and COPD really have a lot of common overlapping molecular pathways of systemic inflammation. So this would at least be additive impact on patients' cardiopulmonary health. There was also some overlap in sort of physiologic altercation of the respiratory system and stress on the pulmonary system. But for the longest time, there wasn't an understanding of kind of what the implications were for this disorder for sleep apnea and COPD. And it was felt COPD is a very common condition. OSA is a very common condition. Yes, patients do overlap because they're both common conditions, but one doesn't lead to the other or vice versa. This was some data from Jose Marin's group in Spain. So that this is a retrospective analysis where they just kind of followed patients with COPD and COPD OSA overlap, and then overlap with and those who were adherent with CPAP and those who were not adherent with CPAP. So you can see patients with this overlap syndrome who didn't use their CPAP machine, had worse survival and more risk of exacerbation compared to the patients who did use CPAP therapy. And you can see they were essentially with the just straight COPD without OSA group. This was another study just looking at CPAP use, and the more you use your CPAP, the less likely you are to have an exacerbation or and there was some suggestion that it might decrease mortality. And that's a big discussion in the sleep world now, is sort of CPAP dose, because we do use this really arbitrary cutoff of using the machine 4 hours a night to sort of meet adherence requirements. But really, when you look at metabolic health, cardiopulmonary outcomes, the more you use it, the better. So, getting up to that 8 hours of sleep at least, and using the machine that entire time probably does benefit people. So these are folks, so this is obstructive lung disease and OSA, and this is just kind of thinking about how these disorders might play into one another. So obviously, if you get obstructive lung disease, you have the disease effects, the systemic inflammation we talk about, steroid use, which can lead to obesity. And then again, the opposite way, the systemic inflammation, this increased resistant load that comes with the upper airway obstruction and upper airway opposed to the lower airway obstruction, really developing this sort of vicious cycle of OSA and this overlap syndrome. So what we've been, this paper by Solier and colleagues from San Diego as well as Brazil looked at patients who had sort of more advanced COPD. So, for the longest time, we didn't really feel like they fed into one another. They were just two common diseases that occurred in the population and just by chance kind of overlapped in individual patients. But patients with more moderate to severe COPD, it seems like there is actually an increased risk of OSA in those more advanced groups. And I think this is really something to mention in West Virginia, because it almost, we do still see that advanced COPD or with, kind of cachexia and, fairly debilitated. But it seems like that phenotype is going by the wayside, and we see more of these just morbidly obese patients with advanced COPD. So this is some work done by Dr. Sharma. Now, this was when he was at Jefferson in Philadelphia, where they looked at patients coming into the hospital with COPD, and they screened them for sleep apnea. And when you looked at their 30-day readmission rate, nearly half of the patients who had comorbid sleep apnea were readmitted to the hospital. And when you looked at the severe group, it was almost 3/4. So it seems sleep apnea was actually playing a role in these readmission rates. When you looked at, and this is just a graph looking at time to readmission or death. And again, you can see how they spread out with the severe obstructive sleep apnea patients. And that, remember, all these patients had COPD, really high risk for adverse outcomes in these individual patients. So there was a statement put out by the American Thoracic Society in 2017 with research priorities and pathophysiology for sleep disordered breathing in patients with obstructive sleep apnea. And there is a lot we still need to understand about, this cohort of patients to really improve their outcomes. These patients do tend to have prolonged respiratory events. And sustained desaturations due to prolonged hypoventilation. And really something we need to understand better. And I think, I don't know how much you guys have heard about this idea of hypoxic burden, but our sort of standard AHI doesn't really capture what's going on with these patients with COPD, OSA overlap. They just have these profound, prolonged desaturations that occur. And we will label it as one event, but that's probably a lot different than your kind of otherwise healthy 35-year-old obese guy who has, a 10-second respiratory event, a 3% desat versus these guys who have, an event that seems like a minute and desats into the 60s, but they are still both scored as one event. And then something that's also really interesting, you guys are probably tuned into the fact that COPD, just like heart failure, a lot of people with advanced chronic conditions do not sleep very well. And this is illustrated by alpha intrusion. So you can see there's these periods on the EEG that are kind of very slow, where the patient's probably in stage N1 sleep, and then it kind of speeds up intermittently throughout the night. So this sleep disruption, one, not only makes it difficult to actually score respiratory events, but it's probably a marker of just poor quality sleep in general and really impacts the patient's quality of life. And we see this a lot actually in patients with particularly poorly controlled fibromyalgia, who are just very sleepy and fatigued, don't have a lot of respiratory issues, but they just have these periods throughout the night where they're essentially awake, going in and out of sleep. And you see a similar thing in this patient cohort.
Dr. Stansbury? This is Dan. Hey, would you go back like 2 slides? One more, right there. Okay. So, no, forward. Go. Yeah, this one. So on this one, you talked. So basically, this is help us understand what we're seeing here. So on this one, you mentioned hypoxic burden and long episodes, and I was looking at this trying to see where the long episode was. Could you just explain this to us, please?
Yeah, so these are abdominal and thoracic rib belts. You see these blue things down here. This is kind of respiratory effort. And this is actually a compressed, like, I think 2-minute epoch of someone sleeping. And then this is your airflow here. So you can see kind of what this patient's normal airflow might look like. They have an awakening here actually. So this is what their sort of standard breathing should look like. And you can see there's this decrease in airflow that occurs, and your pulse ox is down here. They're setting 96% or something here. And during this respiratory event, their pulse ox starts to decrease, kind of stay, this isn't a terrible respiratory event, but it kind of stays low for a while, because again, this is probably a 2-minute epic. It may even be a 5-minute epic. And it takes them a while to sort of recover from that desaturation event to get back to their baseline. So it's really, this is the airflow, and you're just seeing this decrease in airflow that occurs. there's also a decrease in respiratory effort you can see. And so there's decreased respiratory effort, there's decreased airflow, patients not breathing hard, and then sort of they have this point where their airway probably collapses or is near collapse. They get hypoxic, and then they have this sort of gasp you can see here to try and overcome that airway obstruction. They reestablish airflow for a little bit, and then it returns to you see another, probably starting another decrease in airflow. And I think I've talked about this before, but these recurrent awakenings, we always thought about this mechanism where you have this gasping, you have this arousal that occurs, reestablishing the patency of the airway. And if you have a high arousal threshold, that's probably good. But when you have this recurrently throughout the night, you can see that the breathing almost becomes erratic. And, that can occur, that's probably a physiologic mechanism that may actually worsen sleep apnea.
And what about the top? So in a way, this is helping us primary care providers who forget to ask about, have low awareness of sleep breathing or sleep disordered breathing. We need literacy in terms of looking at a polysomnograph and knowing what we're seeing. Yep. And this is a great lesson for us. The really spiky things on airflow I'm talking back at the airflow curve.
Okay.
The really spiky things are the good stuff. Usually we look at EKGs and we think those would be bad, but in this
that's
case,
the good stuff for flow, for breathing. Yeah.
And then the top, just real quick, what are the top 5 lines down to the red?
So I believe is probably the chin tone, this green. Oh, this red's EKG.
Okay.
But since it's compressed, you can't really make anything out of it, because it's when you're looking at a PSG, when you're trying to like stage it, look at the EKG, look at like abnormal movements. We do that in 30-second epochs, but actually when you're trying to appreciate respiratory events, it's easier to look at like a 2-minute epoch because it kind of compresses everything and you can see the desaturations better.
Okay, so for our literacy, PSG is polysomnograph, which is what we're looking at right now.
Yeah, exactly. Yep.
But a compressed one.
A compressed one, yeah, to really bring out the respiratory disorder. So the EEG up here, you can't really make any sense out of because it's so compressed.
Most of us wouldn't make any sense out of it, even if it weren't compressed.
Yeah, it might even be the EOG looking for eye movements. I can't tell there, truthfully.
What's the third line?
So this is chin tone. This is anterior tibialis EMG, just looking for leg movements.
Okay. Okay, great. Thank you. We needed that decoded. At least I did.
Any other questions on that?
Because you're really educating us a lot about sleep disorders, we need to become more comfortable looking at PSGs. We look at chest X-rays, we look at EKGs, but you're really bringing us into the modern era with this.
Well, so while we're talking about this, Dan, you bring up a good point. So in conclusion, sleep metrics are extremely important in West Virginia. And I'd refer you to that first graph of the US I gave you. I mean, it's like an epidemic in Appalachia. I would love to hear if anyone has any thoughts why that is. Interventions to improve sleep health can have downstream impacts. And again, I think, the thing that's interesting about sleep disorders is that, we've been working on a Healthy Harrison project that hopefully we'll have data on soon. And even like a very 2-minute video, it seems like might actually have a big impact on sleep health for these communities. And then as I showed you, there is a lot of interest in this kind of COPD sleep apnea overlap group where you know, for the longest time, there just didn't seem to be too much interest. And then, but it does seem to be, you know, growing interest for an important reason. Now, let me see if I can get my video back. I want to, since Dan brought it up, I want to show you guys something pretty cool. Can you guys see my face now?
Yes.
So this is a new PA, what's called a PAT system for sleep apnea detection. So you have this little device. You put it on your finger like this with a piece of tape. And I'm going to mess up the taping. You wear it like that for 3 nights, and it downloads to an app, and it gets sent to your provider, and that's how you can diagnose sleep apnea. So, you know, the era of using PSG for a lot of these patients has been going by the wayside, but they've still had a pretty cumbersome, like, you know, home testing unit that we've been using. But this new device, really, you just tape it on the end of your finger, and we can get a diagnosis of sleep apnea that way. And it's based on peripheral arterial tonometry. So when you're having respiratory events, it causes changes in the vascular tone that this device detects. Has been well validated against PSG and gets you an apnea hypopnea index based on the number of vasospasms or constrictions you have related to your sleep disordered breathing.
Oh, that's really awesome. That's
Yeah.
really, thank you
Yeah,
for doing this.
Dr. Stansberry, this is really interesting, and actually, I've been living this. My father quit sleeping on January the 1st, so this is amazing, and really getting family docs to understand it, like Dan said, is going to be critical. Are many people using this new device that you just showed us? Is that
Well,
kind of now?
so there's been a device that's based on similar technology called the Watch Pat device, where
Okay.
it essentially wore this glove, but it was actually very expensive for anyone to use because the replacement equipment was so costly that, you know, based on the business model, it didn't make sense for sleep centers to use because they actually lost money because the replacement for it was so much. But this device is actually good for 6 months, and all it costs you is a piece of tape.
That's amazing. And then I wanted to let you know that we're funding the Healthy Harrison Project, so I can't wait to see that data.
Yeah, we've been working with the Rockefeller Neuro Institute. That's what that's RNI stands for, Dan. And you know, I agree with you for the rural tertiary care thing. That was actually something that the editor had us add on.
Whatever she says.
Yeah.
Hey, while Kim is on here, Kim, were you seeing his slides?
Yeah, I can.
Okay, I think probably of everybody on this call, you're the expert. Or maybe we should have you go last instead of first. But you know, he's talking about the he had that slide showing how, you know, extremely high prevalence of sleep disordered breathing in Appalachia. And we've seen that exact same slide for about 20 different conditions. Do you want to comment, or would you be, he's asking for help understanding why there's such a huge prevalence of obstructive sleep apnea in Appalachia.
Not even sleep apnea. I think that's well described by the obesity in Appalachia. But to go back to my slide, what I really need help, I think, understanding is why are just short sleep health metrics. I mean, you look at a bunch of different sleep metrics. Let me see if I can share this again. Why do we think that our population, I mean, this is really impressive. Why do we think that we have such short sleep in West Virginia? like, we have almost half of our population say they sleep, I think it was under 7 hours or 6 hours. I think it was 7 hours, which is associated with, poor outcomes. I mean, does anyone have any thoughts on why that would be?
Yeah, we have tons of thoughts, but I was going to encourage Kim to go first.
Yeah,
Okay.
well, he was going to let the social worker go first, not the doctor, because
Well, that's the upstream that he's talking
Yeah.
about, Kim.
That's right. Well, I hate to report to you guys, my husband walked by and he says, "Oh my gosh, you represent this. You're sleeping 6 hours or less right now." I think it's a multitude of things. I think, of course, obesity is the biggest one, and chronic disease. But I think a lot of our people work shift work. I think a lot of our people can't afford to have the care they need with their taking care of sandwich generation. If they've got children and grandchildren, and we have all of these grandparents taking care of their grandchildren now, and so their own health is failing. Dr. Bob Walker talks about this all the time, and he's got some studies on that, some work that he's doing with rural elders with chronic conditions, and how many of them, their number one issue is they are stressed and not sleeping because they're taking care of their grandchildren. And so, of course, that feeds into the opioid epidemic. And then shift work, I think, is a big one too, and you got little kids to take care of and elderly, but those would be my first guesses. And then, of course, poor diet and lack of exercise, because if you don't exercise, you're not tired, you don't sleep. And I would blame Zoom too.
Yeah.
Yeah, so we're talking about people not getting enough sleep, and
Exactly.
what about Lincoln County and Logan County? You guys, is that something you guys see? And what are your theories about why people aren't getting enough sleep? Logan is Sheila, and Lincoln is Brandy, and Krista is at Cabin Creek. I mean, you're seeing this.
Sheila chatted in saying she completely agrees with Kim. Brandy said, "My thought was the shift work. If you know anyone who works coal industry, they're always working long shifts and swing shifts."
Yeah, so those are really, and what about up in Pennsylvania? You guys,
See, it goes it goes up.
Yeah, all the way up into Benedict's County. In fact, way up in the northeast county.
Yeah, we up here we're shift work as well. I mean, and up in Pittsburgh, we're the steel industry, so we're doing shift work and multiple hospitals in Pittsburgh. So yeah, we're shift work as well, I would say.
So do you think shift work really drives a lot of this? I mean, it seems like, coal jobs are decreasing, right? And a lot of these different industries have been shrinking. Do we think that is a big driver of this?
I think having grown up with a father who did shift work at a factory, so I think as we're gaining, what is it, 6,000 or 20,000 more jobs in 3 factories that are coming to West Virginia. And then I think the fact that people work multiple jobs, so they have to piece together 2 jobs to kind of make ends meet, that they get erratic patterns, and so they don't have a regular sleep pattern is what I would think. But you're right, coal is shrinking, but the people that still work shift works are still struggling with it, I think.
That's a great point.
We have seen this slide so many times. This is a slide for substance abuse. This is a slide for teen pregnancy. This is a slide for cardiovascular mortality. It goes on and on. So, obviously poverty is a correlate. And another thing to think about is part of the reason this is the opiate epidemic slide. This is the methamphetamine epidemic slide. So one other, so I don't think shift work is all of it, but I think it is on my list. It would be very important. Also, it's also where there's a chronic pain epidemic related to the kinds of manual labor jobs people do. We have a really high rate of work injuries that develop into chronic pain that are correlated with opiate use. But I don't think that's the whole thing either. When you think about it, we know that you've taught us that sleep disorders are associated with poor health, and poor health is associated with sleep disorders. So
yeah.
it goes both ways. But the shift work thing is really interesting, and an idea I have for you and Dr. Sharma is to study this in the Ruby Hospital workforce, because a whole bunch of those people are working shift work. So my bet is that right there in your rural tertiary care academic hospital, you could have a mini epidemic of this. And these are healthy, mostly not poor, except for the janitorial staff and the kitchen staff. These are a lot of professional people, nurses, respiratory therapists, and yet my hunch is that it's true there too, and it's based on shift work.
Yeah.
But the big thing to me is poor health creates sleep disorder, lack of sleep, and lack of sleep creates poor health, and all your upstream factors in this region are the contributors to poor health. So and I'm really glad you're bringing this up, and I'm really glad you have that upstream, midstream, downstream slide. You and Dr. Sharma and I have talked about that a little bit before.
I would actually use this as a part of a grant I'm submitting to show why, having this upstream effect, because again, I feel like so many times, we just started a big study looking at high flow nasal oxygen and COPD patients. But again, these patients are kind of at the end stage of their COPD. What major impact are we going to have? Maybe we can improve their quality of life or mortality a little bit. But I mean, when you have advanced COPD that's that's established and progressive, we're really catching them down here, where we need to do things up here that are going to have a trickle down effect on health, right?
Exactly. Yeah, and this is what the social workers and the community health doctors and primary care doctors, upstream and midstream. What we're talking about, we call, our name for that is social determinants of health.
Yeah. Well, and one thing that there's been a lot of work in sort of racial disparity and sort of ethnic differences in outcomes there, but it really does, to your point about poverty, it seems like all these patients have the same thing. They have poverty, they have poor access to care, and they have poor education. Like, universally,
isn't it?
Where? You need to mute, Kim.
I'm sorry. You're fine.
Okay.
Any other questions or comments? I must say,
I think Aaron had a question a few minutes ago asking about what that ring device or what company it's from, and then if you happen to know the reimbursement or what CPT code you charge when using it.
I do not know yet. This is I think going to be coming out in the summer. It's from ResMed, but I think there's going to be a few companies coming out with sort of a similar device to look at the sleep apnea.
Thank you. And Sheila chatted in saying she has a ring device from WellU, I believe. Thank you, Sheila.
Okay. So what we're doing with a lot of our research is the Aura ring. It's probably a similar thing that measures, sleep in individuals. They do a really good job of measuring, and, if you guys have patients who come in and show you their sleep health metrics, these devices, it seems like they do a really good job of measuring like total sleep time, awakenings and things. you know, the big issue with a lot of them is they all have this proprietary algorithm that we don't really know what it is, but it's probably based on like an accelerometer and some PET sort of stuff. But you know, we've used the Aura Ring against PSG, and it does seem to do pretty well when it tells you the different sleep stages. You know, that's probably not as accurate. So if a patient tells you they're not getting a lot of like N3 deep sleep or REM sleep, you know, that's kind of hard to say how accurate that is. But, you know, getting to the opiate epidemic, we actually just did a really interesting study where a company's developing a capsule that you can swallow, and it measures respiratory events we did it during sleep, and compared it to what, you know, we compared what the capsule measured as apneas or hypopneas versus what we measured on PSG, and it was really good. The idea this company has is you can fill this pill with Narcan. And so if someone's going to use drugs, instead of having to have someone get there with naloxone, it can actually measure your respirations. And if, you know, it detects you're going apneic from your opiate overdose, the capsule will break and release the Narcan to reverse it. So kind of interesting. We'll see how, if it ends up working out, but.
That's incredible. It sounds so advanced. That's great though.
Well, thank you guys for all the ideas. You know, one thing I've been really wanting to do is kind of work to see what we can do to improve this in, you know, West Virginia. So I really appreciate everyone's input.
Absolutely.
I think you should also try to present this at the West Virginia Rural Health Association conference, because you would get a whole audience of people that wouldn't be on this echo or may not know this information. Like Dan said, how do we educate the public and the people out there in rural communities serving our folks?
Yeah, I'm on the conference committee, so I'll bring it up. I always feel weird nominating myself when I'm helping develop the program.
Tell them
But
Dan and I nominated you. Dan and I wanted you.
Hey, one thing I just wanted to mention, you were talking about the report on the Ring device. Sometime this year, when you're back on the Echo, it would be really great if you could show us a report and take us through how to, because they're using different measures. You were saying that was like, you know, the vascular tonometry, and we're used to seeing O2 sats and stuff like that. So it'd be really helpful to see a report and have a guided tour of it.
okay, yeah, I can do that.
And one other thing I wanted to say about the you know, about your upstream, midstream, downstream is the American Academy of Pediatrics just came out with guidelines for treating adolescent or childhood or adolescent obesity, and they're great. They take a very aggressive approach because they consider it a dangerous disease, which it is, and of course it leads right into the whole cycle of inflammation and sleep apnea and cardiovascular disease. But once again, in its example, it's coming up with end stage medical interventions for a disease that's really a public health situation, and so we've got trying to deal with the opiate epidemic by having people swallow pills that release Narcan, dealing with adolescent adolescent obesity by thinking about whether to do bariatric surgery on a 12-year-old, and you know, and all the work we're doing with sleep apnea, and the problem is, you know, as you have nailed, is the upstream issue.
Yeah, I was talking to our bariatric surgeons not too long ago, and it like blew my mind. They're actually working towards a bariatric surgery team for a WVU for pediatrics. Like, that's unbelievable to me.
Yeah.
All right, guys. Well, again, thank you so much for all the feedback. And like I said, you know, and Dan's been really helpful. I've been really trying to get a project together to sort of address some of these issues. And you know, what we can do throughout West Virginia to maybe improve this. So.
Thank you so much, Dr. Stansberry, for another great presentation. And thank you all so much for the great discussion and feedback and comments. It really goes a long way, as you all know. So thank you. If there's nothing further, I can go into announcements, and then we're just going to do a really quick poll. And then after you fill out the poll, you can log off. So let me actually stop.